So what I will do is, we have heard a lot about some of the standardization of medical devices, as well as some of the approaches. So what we have done is we have kind of tried to look at why we are doing this, and secondly is there a comprehensive way to look at everything? Because the problem is a lot of the technology is being applied or being developed often. The challenge is there is no connection with some of the end users, and we have to kind of bring everything together, and that's where we try to approach the solution. So fundamentally, obviously the national health policy is out, and we are looking at the big challenges of not enough doctors, not inability to find healthcare at the right places. So some of these are problems, and telehealth as a concept has limited applicability unless you really coordinate it well. So the approach we thought about is to look at, fundamentally we focus on the people. So the comment that somebody made was about Indians is the focus rather than India. And so the approach was to look at, can we access all of this information from anywhere? And can we have somewhat real-time information exchange available? And finally, obviously, the devices which we are going to talk about as well. So if we look at the ecosystem as a whole, so we actually started from the personal electronic monitors and mobile application. I was personally part of Continuum Health Alliance, which is now the Personal Connected Health Alliance. I looked at the standardization. But all of the data has to come to a healthcare management system, which has to be accessed by the patients, by the doctors. But an interesting aspect of it is a community health worker and a telehealth professional. So you have to look at all of the different components of the system. It cannot be limited to just the person or the individual and the devices and system, but all of the components must be together. And we conceptualize the community health workers as much as an important aspect, because these are the caregivers. Often, a lot of the people, end users, and patients we're looking at are unable to actually use the technology. So it has to be balanced. And we have obviously approached it as a rural health solution. So it has to be thought about how it can be applied to anybody in the country. So, and to do this also in a more simple fashion, we took the concept of the health risk assessment driving the whole process. So when a doctor sees us as a patient, they really try to do a quick assessment based on the symptoms we tell them, right? But we often lose the history, we often are unable to discuss all of that in the 2-3 minute discussion, right? So if we can support the doctor with a system where you're doing the health risk assessment with the doctor who is then using that, then you can create a care plan. Now, why is the word care plan being used as opposed to a prescription? Is the care plan includes a lot of things, including what do you need to monitor over time, because you want to see the outcome, whether the outcome is working for them, as well as you're trying to see or provide the information to the patient about all the things they need to do, okay? Which includes taking medication, including exercise, including diet, but anything else that you need to do. Once you have the care plan in place, then you monitor to a care plan, and then again you support the doctor that when something goes wrong or something is not happening the right way, the system can generate an alert based on alert rules. Again, all of these are as per medical protocols. Okay? So the health risk assessment, the care plan creation, the alert process, all of this is as per medical protocols for the country or for the region. And then based on that, you can correlate that is the intervention working for the patient, right? And then based on that, you can offer telecounseling. So sometimes you might get some readings that you're looking at somebody's ECG remotely, and then you could provide some kind of counseling saying that, okay, you need to do something, which could be starting from, okay, take 10-minute rest and take another reading, or you need to go to the hospital right now, we are sending an ambulance for you. So the complete protocol connectivity has to be there. So that's where the service protocol kicks in. So it's not just protocol for the medical devices or the quality of medical records, but also the service protocol that has to be together with this. So that's the important point we're making here. So you've got different roles and different people who are interacting with the system. So you'll have doctors, nurses or care managers, telehealth professionals, maybe paramedical staff who need to look at it, and then the patients themselves. And then you might have local applications, which is a mobile application, which will look at maybe used by a community health worker, which is the ASHA ANA workers, or local paramedical staff, or the patient themselves, if they're able to use it. So all these different aspects has to be thought through when you design the solution. So in the care process flow, what we looked at was how do you apply it in a rural scenario, in a practical sense. So the registration process has to happen in a health center or by an ASHA worker who is going, or ANM who is visiting a person, obviously at home, in case they are unable to come to the hospital or the health center. But then after that, there's a doctor interaction, who creates the health plan, then a task and reminder system. This is a very important part of compliance. So once you create the health plan, it basically creates a calendar for the patient, okay, as well as the caregiver or the health service provider. So sometimes some of the health service provider might be looking at what tests do I need to schedule, or what doctor interactions need to be scheduled. But for the patient, it is every morning they get an SMS saying that these are the 5 things you need to do. So that's the approach we are taking. And the health worker at the same time is receiving some reminders, and who's in the mobile app, they're able to then interact with the patient. Okay? So that's the way they approach it. From a remote care process, the health worker is the one who is kind of in charge. Or if the patient is able to use the application, then the patient is in charge, of course. They are able to upload health data. This health data can come through these connected devices. So you have got an interoperable connected device which can work with this interface of the mobile application, which is the mobile. So mobile phone acts as the gateway for the device, for the data. And then the health worker can also help the patient take other tests. For example, they might need other blood tests which obviously cannot be done at home by these connected devices. There might be other places they need to go to. So health worker organizes all of that. The health worker can also offer a remote exchange with the doctor, so they could hold a video call with the doctor remotely. Again, in case the doctor is remote, quite far away, and the patient cannot really reach the doctor. Right? And so the whole process, what we are seeing is, again, to cater to somebody who's coming to the hospital or somebody who will be at home, and it has to cover different geographical situations. So obviously, the point is here, the whole process has to be highly accessible and secure. So this has to be cloud-based. It has to be anywhere to anywhere, so everybody can look at it. And the challenge of affordability comes to play as well. So my challenge here was, can we design something that you can provide at 30 rupees per patient per year? Why this number? So it has to be a sub 50 rupee number, which even if government cannot pay for it, patient can pay for it. So a 30 rupee number at a yearly basis is 2.5 rupees a month. That should be affordable for any person in India. And that's the way we kind of had to look at it. So just an example of how this kind of system can work. The concept is you get the data, but the data has to be, is not going to look at the doctor. Like you collect parameter data, nobody's going to look at it. But what the system can look at, and there's where the alert rules matter, which can then throw up health alerts. And then you can at a glance understand what is the patient going through. As well as if you look at a patient population view, what you can do is you can, depending on the disease situations, as well as condition, that you can look at a whole patient population at one glance, or you can categorize the patient population. So this is where you not only depend on basic health data, but you can look at analytics, right? You can apply different types of health analytics, and for the same patient population, anywhere you can look at it. Now you can of course de-identify the patient or identify the patient depending on who is looking at the data, right? So from a government perspective, government can look at this data from a de-identified fashion as well, and then say that, okay, this area, we are seeing this kind of disease prevalence, but at the same time, so for example, comment was raised was, so there is a problem of anemia, and we have spent 400 crores, but we have not seen the effect. So how do we look at that? Can we collect different types of data that comes in, environmental factors, regional factors, and then analyze the data of the patients accordingly? So again, you can categorize different parameter sets, and then based on that, actually look at the data. So it can have completely different impact on the whole system. So the point here is that look at a system from a complete perspective. There's a service aspect, there's a technology aspect, and people. All of that has to work together in a certain way. And we can use technology in a smart way, in a user-friendly way, to be able to do this in an affordable fashion. That's our statement here. Thank you.